Two.
We are on TV. Thumbs up. Okay. I am Lori Kelly. I use she, her pronouns. I'm the planning and evaluation manager at the Joint Office of Homeless Services.
Hey folks, my name is Yoni Khan. I now work at Northwest Pilot Project, which serves older adults, extremely low income, experiencing homelessness and needing assistance being moved into stable housing. Just a bit about myself. I previously worked in the healthcare world for a CCO. I now work in the nonprofit sector. I have some experience at OHA, and I think what I wanted to share about myself is I come from a family of refugees from Iran. So I grew up in a multi-generational household that spoke 3 different languages. And so I've kind of seen the multi-generational trauma that's occurred as a result of kind of moving around the world as a result of political conflict. And then layered onto that, I had a sibling who was 18 years old and was diagnosed with leukemia. And he passed away. I was his bone marrow donor. And so that's what brings me to this work, is my own experiences in my life have pushed me to better understand the intersection between health and housing. If you could just imagine, like, coming from a family where many people speak English as a second language and having to navigate a bone marrow transplant for a young adult, it's really hard. And I kind of focused on this area of my career because I really wanted to make some change as a result of all those things that had come before me. So anyway, with that, I'm going to pass it back to Lori, and we're super excited to be here with you today.
We are, and thank you for sharing that. That's incredible. So I'm going to mention that we're going to talk about things that I feel like fall squarely outside the wheelhouse of housing as a general rule. So I'm going to assume there's a range of understandings around everything that we are talking about, and recognize that it's hard to hit all the right levels of depth when we're talking here. So before I start going, I wanted to get a quick show of hands with no hand at all if you don't have a background in this, to 5 fingers if you feel like you just understand. How well does everyone understand Medicaid and OHP?
All right.
Okay, so a broad range. So how much do people feel like they understand the new waiver that just came through, even what a waiver is? Oh, fantastic. So this is letting me know just kind of where we're at, and we are going to try to move through this quickly so there's a lot of time for questions and answers, and recognize that some of the things we're saying are like a drop in a puddle of a sea of information that we could give you today. So anything that can't be covered in the time we're here, we're more than happy to follow up with a Q&A written after. So we'll be talking about 3 different areas today, Medicaid and health-related social needs benefits. And this is just going to be a brief overview of what we understand is happening with the Medicaid waiver and health-related social needs benefits or housing benefits. We'll then be talking a little bit about not just bringing money into the housing world, but connecting housing to healthcare. So medical case conferencing, what we can do outside of this waiver with pre-existing funding. And then a little bit more about what's going on at a program level innovations. And we'll try to leave a lot of time for Q&A. So I'm going to start with the health plan. So Medicaid exists in every single state. In many states, it's when you think about state Medicaid, it is a state-run program that generally has a list of rules around who can receive it. In many states, how it works is there is a pre-existing federally determined list of things that will qualify you for Medicaid and a suite of services. Each state has the potential to submit a waiver, and the waiver allows them to fund Medicaid in a different way with different qualifications and different benefits. There's a standard in a waiver, which is basically they're taking the same pot of money and they're redistributing it in a different way. OHP is Oregon's Medicaid waiver. Our waiver over 5 years has to be resubmitted, and each year in Oregon, we've resubmitted it with a different set of rules, a different set of benefits, and a different set of standards. So in Oregon, we call Medicaid the Oregon Health Plan, and covered services range from typically covered services like physical, oral, behavioral health, care coordination, substance use disorder treatment, to now some a broader kind of swath of services. So just generally understanding, the Oregon Health Plan can be applied for at any time. Federal rules set minimum standards, meaning you can't set a waiver up so people will get less, but you can set it up so people will get more. And then part of the waiver, it's often called a waiver demonstration. The demonstration is showing that delivering services in a different way produces better benefits. So for example, saying, we're going to give some housing benefits and you're going to see better outcomes because people who are homeless can't experience better health outcomes is a way that a waiver might try to demonstrate other health related social needs. Another thing to know about the Oregon Health Plan waiver is that's where CCOs come from. So has everyone heard the term CCO or Coordinated Care Organization? CCOs are unique to Oregon. Many states have versions of a CCO, but our particular CCO structure, which actually embeds a lot more control inside a CCO, is unique to Oregon, and a lot of Oregon structure sort of hinges on the delivery of services through a CCO. So just for understanding. Every 5 years, Oregon must renew the agreement. Every 5 years, we throw out a bunch of new things that we want to see in the waiver. And this year we have added health-related social needs. We have also extended OHP coverage for up to age 6. And then also this particular waiver smoothed out some transitions of care between people experiencing the justice system or involved in the justice system and some other areas where often in Medicaid, people will go off of Medicaid when, for example, they're incarcerated and then have to reapply for the program when they come out. So they're attempting to figure out where are people lost in transitions of care. So that's a lot of what's going on with this particular Medicaid waiver. And there's a lot more to say, but I'll just leave it at that. So today we're going to talk mostly about health-related social needs and in particular housing supports. This particular waiver has 3 areas, and these are HealthShare slides, just so that I wasn't interpreting what HealthShare has been sharing. So you'll see the little moniker in there, and I asked them just to borrow it. But there's 3 particular areas that this waiver is leaning into supplying benefits for. Climate supports, so air conditioners, heaters, air filtration devices, housing supports, which include rent, temporary housing, utility assistance, pre-tenancy, a bunch of things that you're used to seeing in the housing world. And that will be up to 6 months, just to clarify, because that's a big part of what we're going to talk about in a moment. And then food support, so nutrition counseling, medically tailored meals. But there's a thing I want to highlight about Medicaid that's different than the housing world, which is it's an entitlement benefit, which means that everybody who qualifies for a service gets that service. So unlike in the housing world where we're going to try to prioritize people and have our particular groups that we're working with, if you qualify for a service, you're getting that service. So they are required to start with a population they know they can serve. And they're going to need to figure out a way to get people into services as quickly as possible and ensure that they have a network that can do that work. So it looks a little different. And it's a little complicated to align a housing system that's always worked differently with OHP system that requires people to deliver a benefit. So this is a little bit about the timeline. Some of the housing benefits will launch November 1st. Food benefits are planned to launch in 2025, and the climate benefit already launched. So I mentioned a minute ago that with an entitlement benefit, you're going to need to get people, every single person who qualifies to that benefit. How they tend to manage this in a waiver is even though the entire waiver is written to serve a lot more people, they're going to narrow the population at the beginning to ensure that they can get that particular population to that benefit. So when this benefit starts up in November, it's going to be people who have OHP, plus people who meet the HUD definition of at risk of homelessness, plus need support to maintain their current housing. And for broad translation, that means people who are not currently homeless, people who are at risk of homelessness. So that's where they're starting. And as I understand it, that they started in this place because, as we know, money doesn't necessarily equal housing. Trying to find housing is a complicated thing. So this way, at least they can try to prevent some people from becoming homeless while they figure out the rest. In addition to that, they're going to need to have one clinical risk factor. So there's a bunch of ones here. Some of them are physical, some have to do with age. And so somebody will have to be, and I'll talk about in this minute, clarifying that an individual qualifies under these 2 areas. And they'll be eligible for things that people would generally need who are already housed. So some of the hotel vouchers and move-in costs that they can cover under the waiver won't be available yet because people are believed to be already housed when they receive this benefit at this particular stage of the game. And I've just put up here HUD's at-risk of homelessness definition. Many of you already know it. It's a little complicated. It's not necessarily a one-to-one, meaning in some cases, people may qualify for OHP, but not be in the at-risk of homelessness or vice versa. And there will be screeners to try to figure out that sort of myriad of qualifications to figure out if you qualify. So once again, I'm just going to share what's coming up in November. So rent and utility services, utility arrears, storage fees, tenant services, and home modifications. Please, go ahead. We do have a Q&A time, and we're actually happy to take questions now if you need clarification. Mhm. This is a great question. So I'm going to try to encapsulate your question a little bit, which is some of these benefits are already covered under flex funds and there's a process to get to those. Will it be the same process? Will they immediately qualify? The answer is no. So there will be a different process to get to this benefit because it's now a benefit, not a flex fund. With a flex fund, you can move outside of the normal qualification processes of Medicaid and CCOs can set up their own sort of process. It will look different. One other critical thing to know about flex funds, and I won't go too deeply into this, is that flex funds are there to cover what's not already covered under Medicaid. So you can't use a flex fund for a covered services. So basically, there will probably be some processes of you apply for the flex funds or apply for the benefit. If you don't qualify for the benefit, you can go through the flex fund category. But as a reminder, CCOs can deny flex funds, but they cannot deny an entitlement benefit. So there's the whole process you can do to contest this and so forth. If, for example, you believe you actually qualified under the benefit, and that's a key difference. How this is going to look per CCO, I'm not quite certain, but I would guess that very little housing will go through flex funds from here on out if it's a covered benefit.
The last slide.
Apologies. Yes.
It said 6 months per eligible.
Yes.
So you have a family and all 3 members of the family qualify for OHP. Is that 18 months of benefit?
Yes, yes, good catch. So that's one thing we mentioned, we noticed, so let's say you have a grandmother who's over 65 in the household and you have a kid under 6 and you have somebody else in the household who qualifies under one of the medical needs. Potentially you could have up to 18 months of benefits, which is why this might be a really interesting benefit for families going in, trying as we move forward. But also the 6-month thing has the housing world a little concerned in other ways. And I'm going to walk through what the hub model is going to look like in a second, because I think all of you can figure out where there's a lot of cliffs and valleys and funding cliffs in people who need rental assistance without me saying it. I just saw a hand in the back. Yes.
So I'm wondering what sort of grace there is.
Yeah, so there was a question around the slippiness of pre-housed versus at-risk versus not, and I think that's still a pretty flexible area. What they're really attempting to get to is people who have a lease, or as I understand it, and we'll be working with some of the screeners. I'm going to talk through the process in a second a little bit. And I want to clarify, I'm about to share what the process will be in a minute or two, and there's a lot of gray areas still that we're working out, and the counties and housing partners are really trying to weigh in on what sort of flexibility is necessary to make this a useful benefit and what sort just creates gray area that makes it hard to administer the benefit. So I'm just going to quickly put this up here since basically the community capacity building funds applications are due now. And I'm sure most people who know they're going to apply have already planned to apply, but there have been community capacity building funds made available to help organizations who think they might like to utilize the waiver build up administrative capacity. You do not need to apply for these funds to bill Medicaid if you're planning to do so. They're an opportunity. There will be more coming forward, but basically they're there to try to build up capacity around network hubs and providers to make sure that, let's say you need somebody to administrate the fund, you could build up that funding through the capacity building. So that's going on right now. It's also going to help HealthShare understand who's likely to be accessing these funds or administering these funds in the near future by these applications. Yes. Mhm. The capacity funds can do everything from internet capacity or billing capacity to anything that's infrastructure, but nothing that's service delivery. That was the idea behind it. It's an infrastructure building grant, not a service delivery. The idea is that service delivery, and we're discussing this with the various groups, can be supported through billing. But we'll see how that, how that looks. And I think there's always an administrative fund, and I think that's been sort of the fun process of figuring out how much needs administrative funding versus how much can actually directly being supported through billing. And I think there's a little bit of glide path there too, right? Of figuring out how to get things running so you can support it through billing versus the initial capacity building. Yeah. So I have this up here. This particular structure is a structure that HealthShare has been leaning into with some feedback from housing providers in the county. This structure is not the same structure outside of the Tri-County area. The Tri-County area leaned into talking with OHA and HealthShare when we first heard about the health-related service needs. And I think some of you can probably guess why. When you have 6 months of benefits and a system moving outside the housing system, there's a lot of concerns about the many places when people might call in to get a benefit where they might need more than 6 months of a benefit, where they might not qualify for this benefit, but might qualify for another benefit, where basically there's space to coordinate around ensuring that people receive the kinds of services they need, and recognizing that there's opportunity with the supportive housing services measure there to try to make this whole and make this a more effective system. They work together to put together something like what you're seeing here. So there will be a front door, and that front door will clarify who is available for the benefit based on what I described before. Do you have OHP? Are you, are you one of the service populations and so forth? That front door will hand off to the health plan, which is basically the central authorizer, to clarify and give the go ahead. Yes, you can get these benefits. And then there will be a network hub, and the hub is going to be more than likely counties stepping in to ensure that managing the contracts, making sure that housing providers are truly housing providers, and also ensuring that the housing plans that are being developed are considering the equivalent of a discharge plan at the time of the service. So meaning if somebody needs, when we look at them, clearly more than 6 months of services, what can we do to try to line up something on the back end so somebody is not just kicking a can 6 months down the road in the eviction prevention process? So that's a little of what we're doing there. And then there will be service providers who will do everything from helping people get their rental assistance to the wraparound services that were described in the benefit. And I think part of the difficult thing right now is how do you coordinate around these services and integrate other pre-existing resources that are there to ensure that people are really getting all that they need. And the hope is that by having a hub, you're also going to be connecting other pre-existing funded Medicaid services, social services there, so that you're really not just briefly holding somebody and then passing them into homelessness. And so that's kind of beginning to transition towards what we're going to talk about around medical case conferencing. Yes. 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 More than likely. Yes. Through the county. That's what we're trying to figure out right now, whether it's going to be a direct billing or whether it'll go through the county. And one of the things we're trying to figure out is how do we make sure the funding flows fast? Like would you need a trust fund up front to make sure that you can pay the check and get reimbursed? Because one thing that's very different in the housing world than in the Medicaid world is reimbursement processes, right? Like you're not used to waiting 14 days for a check and waiting to see. You're used to being able to do that up front because landlords don't wait for reimbursement. So I think that's been the tricky thing. And I'm just going to be transparent and say that we're still navigating that really proactively with healthcare, but we don't know what that's going to look like yet. But everyone's calling that out as much as we possibly can, because otherwise, the last thing we want is somebody asking for these funds and by the time they get them, being already evicted, right? Like that seems like the last thing we want. So I'm going to be transparent. There's a lot that we're still working out, but this is the general functions they had imagined each entity would serve in their process flow. And we're working really closely with the front door entry people as well to try to figure out how do we streamline that a little bit so that there's not too many opportunities to be dropped in the process. So I talked about a little bit why a hub, and it's really to identify funding cliffs, supports the no wrong door vision, and promotes system alignment, because we're also recognizing that the minute you start interacting with Medicaid, there's a lot of other opportunity there. If somebody, in my head, if I have a client who is interacting with Medicaid to get housing, shouldn't they also be interacting with Medicaid to try to get to behavioral health resources? And shouldn't they be trying to get to a primary care provider? And if we're making sure they have OHP, shouldn't there be more involved in the mix? And so approaching this as not just a new administrative complexity or a new funding stream, but as an opportunity to really think about how we move people through multiple systems at once is the name of the game, and we'll try to create these hubs. So I'll stop. Yes. Right. That's exact. So the accountability question is, the question was, where's the accountability? A hub was created exactly with our worry about the accountability, because we were worried in the way that Medicaid billing works is that somebody would just get 6 months and nobody would ever follow up with them because they don't really have the understanding of what it means to be a housing navigator and to understand that people would need more than 6 months. So our understanding is it would be a combination of the healthcare plan and the counties ensuring that there's accountability, that somebody has a backup plan when they start to get the 6 months, not when they move along. And again, that's some of the process of trying to figure out where does the accountability live and what are the checks and balances to make sure that everybody is getting what they need. And I think it's going to be a learning process, to be frank. So before handing this off, I wanted to mention that there's some other areas where, as we're building this, we can coordinate around ensuring that people really come to more than the housing benefit. And I think I was beginning to allude to that. If you're getting somebody in a room to understand what they need for housing needs, shouldn't you be getting them in the room for all their various needs? So inside the county, we're beginning to build some processes with partners to really think about how do we coordinate around services more than just Medicaid utilization. So one thing that's going to be happening in the near future is a pilot we're launching, and Northwood Pilot Project will be part of it, around medical and healthcare case conferencing. So it's applying people who have social service and healthcare understandings to the already existing kind of chat function for a particular group. And we're going to be starting with aging populations who have particular behavioral health needs to really sort of concentrate on this very complicated population and figure out what they need. And we're excited to get that going. We're also working with healthcare-led projects like discharge planning and expanding projects like Fuse that really look at multiple systems to try to figure out where are people being lost in systems and to think about where the accountability lies per the question that was just asked. And then finally, exploring information sharing on multiple data systems to try to figure out how do we catch people as fast as possible moving through systems. See, there's a hand up. Yep.
And a lot of folks who have behavioral health needs are low and homeless customers.
Yes.
But also all the over from the behavioral health related to the aging. We used to pick up one spray together to deal with and two, I have always less about this, and I was probably working on leadership, but it would be great to connect, because we found that especially folks with ages connecting.
So the question was, with the particular population that will be part of the medical case conferencing, are we considering the multiple waivers that cover their needs, and are we coordinating around it? And the answer is number one, yes, we are coordinating. One of the first call outs we had is we wanted aging disability in the room to talk about what other benefits are there. Waivers can be complicated, and in some cases one can override another, but I do not believe, because they go through different avenues, these should cancel each other out for one of another term, like some of the in-home supports, which
Mhm.
can be kind of weird. I know, like, sometimes you go through behavioral health or sometimes you go through disability or, and you can end up locked out of both as a result. This particular benefit shouldn't interact like that, but I think it's our role right now to recommend how it doesn't. So that's part of the process of getting everybody in the room at the same time. And with that, yes. Yeah. I think that's a great call out. So just saying out loud that I think it's part of the role to make sure that the multitude of different opportunities for services inside waivers are not being missed as you're navigating a complicated population. And I think between the multiple waivers and there's also state plan amendments, they call them SPAs, it's often very complicated. And one of the reasons we wanted something like a hub was to say you need people in the room talking to each other. You can't just keep handing people off, right? Somebody needs to create a housing plan for someone with these ideas in mind. If you're documenting inside Medicaid, you should document it all, right? So yeah. Yes. Oh, no, that's fantastic. And I think I just want to summarize for people not in the room that effectively as somebody who's worked in multiple areas, it's really easy to be shut out of one part of a benefit because you qualify for another. And just, gave a little bit about his background. In addition to having worked in sort of the provider world, I actually came from OHA as well and had the critically fun experience of getting to see people eliminated from one waiver that I was helping support to another. And I know it's pretty ridiculous. And I think the last thing I will say is one of the reasons this is being done both at a county level and at a provider level is to try to identify where there are policies that really are getting in the way of us doing better programming and recommend to the state and higher levels where there are opportunities to either fund programming that's missing or smooth out some of these issues, or at least create communication flows between these issues so that people aren't caught forever in these sort of wedges of space where they can't get to one benefit that's better for them because they got another benefit. So with that, I am going to hand it over to you.
Great. Thank you. You want to move over to the next? Oh, no, that is the next slide. All right. So I'm going to kind of pivot a little bit. I think the way I view the waiver is it's a new tool. It's a new tool that brings with it new funding resources, but it is not a solution to everything. New tools require a vision to maximize efficiency and effectiveness. So as I'm talking, what I hope you'll be thinking about is kind of where does the waiver fit in this kind of dichotomy between crisis response and long-term housing retention? Where does the waiver fit in with programmatic success of an individual organization like my own versus what Lori's describing as broader, higher level systems change by identifying policies both in organizational and county, statewide level, again, to maximize efficiency and improve equitable outcomes for the people we serve. This is Northwest Pilot Project. There's a bunch of stuff you can read. What I wanted to kind of relay across here is why we're involved with this work. So the day I started at Northwest Pilot Project, I started interviewing our staff to better understand where advocacy priorities were. And I want to give 3 client anecdotes. We had a client we were working to house for a number of years. Client had a history of behavioral health and mental illness, but generally could navigate the world on their own independently. Again, we're pouring resources of rent assistance, case management, housing navigation to stabilize this individual, and they're getting medication to stabilize their mental health condition. What happens is the client loses their prescription. They don't have access to these meds that are stabilizing them. And because we are in a relationship of trust with this client, again, we're checking in with them for multiple years as we're moving them from the street to stable housing. There's just that relationship there. And so the client calls our caseworker up to say, hey, I need my meds. Caseworker does everything they can to get the prescription filled. No one bites. A few days later, the client ends up being pulled off the street, having an episode, and is brought to an inpatient psychiatric center. Calls up the case manager from the psych center and says, they've stabilized me. I've been here for a day or two. They've stabilized me, and now they won't fill my prescription. The same exact thing is going to happen if I am let out without my prescription. So our caseworker, very experienced guy, has been doing it for decades, calls up the discharge nurse at the psych facility. Please do not discharge this client. We are housing them. We are pouring resources. They are supported. Please fill their prescription before you discharge them. We don't hear anything. A couple months later, we get a letter in a pink envelope from a penitentiary in Idaho, and it's this client. She was released without her medication. She was picked up for having another episode out of state, and writes in the letter that she feels lucky to be in jail because she's finally getting her medication. That's a challenge. Another anecdote. I do door knocking from time to time to visit clients. We generally check in on clients weekly to make sure they're doing all right. Knocked on somebody's door, went in, they said, come in, go in. Person sprawled out on the bed. Their foot has been amputated. There's bloody bandages on their leg. What happened? Are you doing okay? I just got my foot amputated due to frostbite, and I'm really hungry and I'm in a lot of pain. Can you help me? You know, within a couple hours, we got them a grocery bag, right? But again, this question of the cracks in the system. Somebody is discharged with a support team from a medical environment, but they're sent home without any supporting services or coordination with a contractor that's funded by a public entity. And had we not checked in on this person, I don't know what would have happened. They would have been stuck in their bed with a bleeding foot without food. So again, where can we work as a system to improve things? Next slide, please. Yep.
The answer is the hospital. And then they're doing this service all the time. Is there connection with the hospital system?
That's what we're going to talk about. And I think that's where a lot of this hub model has the potential. It's not just the hospital. What I will say is our medical providers and our healthcare system is also in a workforce crisis. Everyone is stretched thin. People are burnt out. My wife is a healthcare provider, comes home every day, like craziest stories I've ever heard, day after day after day. I think what we need is a new paradigm shift. We need to pivot towards cross-sector case conferencing, which involves input from housing service providers, jurisdictional funders like the city and county, and health systems. There needs to be a new model for joint accountability because, quite frankly, and I'm going to get into this in the next slide, the acuity that we are seeing with our clients who do not reach the level of acuity of needing to go to an inpatient psychiatric facility is so high that it is harder and takes a lot longer to stabilize them in housing. So the current landscape, increasing client acuity. If you had looked in on the data about our clients 5 to 10 years ago, you would see an even spread of 0 area median income all the way to 60 area median income, meaning extremely low income to 0 income, all the way to still making it, but it's really freaking hard for this person. Today, if you were to look at our data, what you would see is the clients we serve are almost over 90% 0 to 30. They come to us having been on the streets longer. They come to us having been on the streets with more medical complexity. We specifically serve older adults, age 55 and over. Even if you're a stably housed, well-to-do older adult, your body is changing, your body is decomposing, things need to be addressed. Now, layer on to that, trying to survive on the street because you lost your apartment due to affordability issues. It's an acute population, maybe not as acute as needing to go to the Oregon State Hospital, but it's bad and it requires a different level of care. There's limited client access to behavioral health, substance use disorder, and primary care. So part of it is the health system. Part of it is also the need for transformation around housing service providers. Quite frankly, we have been developing a model for 54 years that we've been in existence. When a client has a medical issue, well, we send them to the Lions Club for glasses. We send them to a free dental clinic and a high school parking lot for dentures. And if if a physical health issue comes up, we send them to urgent care. That's how our system or lack of a system was built when it came to healthcare issues. Wasn't such a problem when, again, you're dealing with an even spread of area median income and people who haven't been on the streets for years at a time. The landscape has changed, right? And that's where we need better coordination. Next piece. So there's also this layer of urgency to address visible homelessness. And that's where I want people to start thinking about, it's not just about getting people and clearing them off the streets and making our communities more aesthetically pleasing. That is a part of it, and I don't want to undermine that that needs to be a part of it. At the same time, we need to start thinking about housing retention. We need a new model of coordination because you cannot just put people in apartment units who have ongoing needs and wait to the level of a catastrophe or a crisis that sends them to the ED, a psychiatric facility, or the carceral settings, prison, jail, what have you. Can't wait. We don't want to wait. So how do we build both at once? How do we pivot towards a system that allows for access to care for people who are currently utilizing public resources and are in the process of being housed, while simultaneously addressing the crisis response? Because there's going to be a need for crisis response. I think we all know that, right? Even if you do all the upstream things necessary, it's not going to catch everyone. But it can't be waiting for everyone to fall through the cracks and having crisis response come in. Next box, I guess. This is important. I described to you how we're doing kind of care coordination in the housing level with sending people to the Lions Club for glasses, which, by the way, means when they get vision issues, they're getting glasses, but they're not getting checked for glaucoma. They're not getting checked for diabetes, what have you. You know, same with dentures, same with physical health, right? 100% of the people who move through the homeless services system in our state are eligible for OHP. 100%. There's a coordinated care system. 100% of the people are eligible for OHP. Now, from our vantage point, from our orientation as an organization, you have to understand, people come to our lobby not knowing anything that they're connected to. We're working with them to get ID to simply apply to housing. We're working with them to identify sources of income that makes them slightly above zero income. We're working to pair them with rent assistance, and we're working with housing navigation and case managers to try to make things suitable over, and it takes a long time, right? The question is, how do we know what their health plan is? We don't. When we screen for someone's health plan, the most frequent response that we get is, well, I was in the ED about 6 months ago, and I was homeless at the time, and I didn't have a permanent address. And they might have signed me up for something, but I didn't have anywhere to send it. So I never got any follow-up. That's what we often get as a response when we ask, what is your OHP plan? We know they're eligible. What we don't know is, have they been kicked off the redetermination? Do they need to be re-enrolled? Are they assigned to one CCO or another CCO? And beyond that, who's actually administering the care at the health plan level? Next box, please. So we want to move away from these workarounds of sending people to the Lions Club, and that's where cross-sector coordination is going to be key. And this is the vision that I hope to layer on top of the unique tools that we have now as a state to better address this as a state and a region. We want to work away from the workarounds, and we want to be more closely integrated for joint accountability with jurisdictional funders, health systems, and housing service providers that manage these populations directly. Last box. Wages and workforce play into this. 1/3 of our direct service staff works 2 jobs, and they're working with really challenging populations. when you have a caseload of 25 people and 5 years ago, you could manage it because, again, nobody needed to go to the ED. Nobody needed to necessarily be on all of these complex medical monitoring, like situations. Well, now our caseworkers are managing the same number of caseloads, but everyone's sick. Everybody is presenting with physical health deterioration. They're presenting with behavioral health, substance use disorder, and care coordination is more needed than ever. Because as social workers, we can address to stabilize people in the housing realm. What we can't do is make a medical diagnosis. What we can't do is pivot away from, what our actual work is on the ground in permanent supportive housing settings and figure out how to navigate a very complicated health system where we can't even identify the CCO as a starting point to get that person engaged with regular care. Next slide, please. So we have the Regional Supportive Housing Services Funds. We have the Medicaid health-related social needs, and I think that needs to come together as part of a vision. We need to be able to utilize these tools in a way that's going to address the problems I'm trying to highlight to you, which again comes down to very specific suggestions around what would really help our clients and staff on the ground. Next slide, please. So I have a couple recommendations, 2 of them. Number 1, for access to care, we need help identifying the payer, the coordinated care organization, the health plan. Where do we go to have an entry point for care? We can't go anywhere without knowing the CCO first. Or if the member is in fee for service from a Medicaid perspective, we need to know that too. But we need to basically have, what is the first step we take? Because right now we're doing this in the dark. Number 2, cross-sector case conferencing. That involves regular check-ins between the people working on the ground to house this individual who can bring up, hey, this person's reporting numbness in their left arm. This person's reporting that they're fearful of relapsing due to a traumatic event that happened in their apartment. We had a client not too long ago. We walked in to check in on them and they were collapsed on the ground because they had a bad reaction to chemo. We happened to find them, right? But again, that's something that could come up in cross-sector case conferencing that involves kind of strategic insight from jurisdictional funders, allows for the perspective of healthcare providers who help manage the care and point us in the right direction, and also input from the social services, the caseworker who knows the client best and can tell you, this is the best way to get them to care. This is what they're asking for. How do we work through this? So those are my 2 recommendations. Next slide, please. Streamlining access to care is really important, and I'll hit on this over and over again. We need to know the CCO, and it is really hard. It takes a lot of effort to figure out the CCO if you are not a Medicaid rendering provider, service provider that bills Medicaid. We don't have access to that information. Yes, HIPAA is a barrier, but also HIPAA was created as a pathway to exchange information, not to necessarily restrict it. And what we're in right now is a situation where we cannot navigate people to any coordinated care. What that means on the large scale is, there's a presentation across the hall on population health data, looking at claims and utilization of the health system and how people who have certain diagnoses utilize the health system. Well, if I have a client that had a manageable health condition, a manageable behavioral health condition, and I'm working with them and I'm sending them to the Lions Club, urgent care, and dental clinics to get health care, the only time they're going to show up in claims data is when all those things fail and they end up in the ED. So part of my concern as an organization is we're worried that our clients are invisible until they hit rock bottom. And only then, post-institutionalization, can they get connected to the resources they need. And the ask is, how do we figure out how to do this effectively more upstream while also building out the crisis response piece? Both are needed. And that comes to, we need just a clear access pathway. We need to work collaboratively as a cross-sector entity, and not to put words in Lori's mouth, but that hub could be a good precursor to this cross-sector case management where we develop clear access pathways. I'm not expecting behavioral health providers to parachute into clients' apartments. I know there's a backlog. What I am hopeful is that we can identify the payer and create pathways so we at least know how long the wait is to get into care. We work with clients to house them off the street. Sometimes it takes up to 3 years. It would be helpful to know if a behavioral health assessment is coming in 6 months. We can work that in. We can keep the client moving and keep the client stable, but we want that connectivity to be able to monitor things without burning out our workforce. Next slide. So one tool that is available, which I would recommend exploring further, is business associate agreements between community-based organizations delivering housing services and health systems, whether that be the CCO or the health plan themselves. Now, what does this all these things get you? Well, what I'm looking for is there should be an option of compiling a list of people that we serve in our organization that we know are OHP eligible and handing that list off to a CCO, a health plan, some sort of responsible cross-sector group that says, here are the 100 names, 50 are assigned to this health plan, 50 are assigned to that health plan. That's who you go to access care. Right now, we don't have that. And it is the most basic barrier to getting upstream preventative care for clients who otherwise need to wait a long time to get an infection treated and could end up in the ED otherwise because we couldn't get them into primary care. So there are options without major system transformation and building gigantic platforms that we can explore before we just kind of build the wagon itself. Next slide. So, you know, I think what we also need to be open to in this moment is a bilateral referral system. The waiver largely concentrates on referring people outside of healthcare, from healthcare into housing, right? You might be part of a transitional population moving from the Oregon State Hospital to some sort of housing setting. That's where the Medicaid waiver kicks in as that transitional benefit. What I'm talking about is, let's also think about referring the people who utilize the Medicaid waiver or who are eligible for OHP, referring them from housing settings, which admittedly are less sophisticated when it comes to Medicaid compliance, back into the healthcare system to get that care and that joint accountability. Recognizing there's huge barriers and that this is not on the hospital systems and the CCOs alone to address this. We're in a public health crisis with our medical system. This is a collective responsibility. The goal here is not to point and blame at anyone, not the county, not health systems. What I'm advocating for is let's change the frame of mind. Let's change the lens through which we approach this, because the old way is not working given our client acuity. And again, it comes down to designated entry points and clear pathways. Next slide, please. So what we're hopeful for is, whether it's through the HRAP process or some other process, creating referral mechanisms, community-based platforms that we can have a conversation on the barriers and identify pathways to move forward in order to get clients connected to care, and also to these wonderful new tools and resources that are coming down the pipeline from the waiver. Case conferencing is going to be essential, because there are folks who are so medically complex right now, who, by the way, like, you could walk by them on the street and you wouldn't have a clue, right? Because you're not in their apartment trying to house them, but they are medically complex. And especially when you get to this older adult population, they're more medically complex than probably any other group. And so with that, the case conferencing is going to be pivotal. Coming up with a model. What I wanted to highlight is we're working along with 4 or 5 other community-based organizations on a pilot with a group called Project Access Now. Some of you might have heard of PANOW, Project Access Now. But essentially, we've identified 5 community organizations, Northwest Pilot Project being one of them, where a community health worker who has knowledge to navigate the health system through, you know, an electronic network, access to MMIS and all the HIPAA stuff figured out. What we are working towards is embedding a community health worker in different housing settings to understand what the barriers and opportunities are to coordinate care from those settings. So that looks different in a shelter than it would look like in my organization, where we're in the process or have already moved people into housing. And that looks even different from a community development corporation, which is essentially owning housing and being a landlord. But the point is these same people, they're OHP members, they're in shelters, they're being navigated throughout different systems, and they're living in affordable subsidized units, but they're the same people. They're being served by different systems. And what we want to try to figure out is, what is a realistic expectation in a shelter setting for giving someone care when they don't have a stable home to go, to go to at the end of the day, or where you might not be guaranteed ongoing check-ins with them. And how does that change when you've already placed someone in a low-income, affordable apartment and they have that place to go to every night, but still need ongoing supports and services to help them? So that's what we're working through with this pilot, and we're kind of testing it out to be able to monitor and again, get out of this place of just programmatic success to more of a what policies need to be elevated in order to promote better equitable change and transformation in the system at large. Next slide, please. So the goals and outcomes, I think I spoke to them, but essentially what we're looking for is better integration and joint accountability between social services, jurisdictional funders, and health systems. We need a new way to manage this situation, and it needs to be humane. It can't just be moving people off the street without a plan. It can't just be warehousing people without a strategy around housing retention to keep them in the apartments that we are placing them in. Next slide, please. Barriers to consider, there's a whole host of them. I'm sure you've been thinking about them this whole time that I've been talking, but you know, the healthcare workforce challenges, as I said, they are no joke, and I don't want to undermine them because those are good people doing good work to help people every freaking day. And we should be proud of our healthcare workforce. And also, we need to pivot a little bit outside of the immediate crisis and think through how clients do not have access to care for a benefit that they are entitled to under OHP. HIPAA, you know, I threw out their business associates agreements, I threw out their MOUs. We worked through a lot of this stuff between our organization and PANOW in order to get access to some limited information that helps us better direct care and better pursue access. I think these are surmountable, but there are also things that need to be worked through collaboratively and could require changes to workflow. Central administrator, Lori hit on that with the hub. That's going to be a big lift, and that needs to be iterative. It's not an all at once type of thing. We need something that works, and then we need to build it out over time to make it better. And then guidance from the state. We need guidance from the state around how to do this work, and as things change, how to update this work and how to be better connected as housing entities and Medicaid entities that work together to serve the same population more effectively. Meaningful cross-sector collaboration is going to stabilize our workforce, and it's also going to improve client outcomes. Next slide. I'm done. That's it. Happy to take any questions.
I'm wondering, since we have two microphones here, if you want to take one to the crowd, and then we can share the other one up here.
Hi there, I'm Scott again with the city. Thank you.
Hey.
I just want to raise up right now. I am amening you on all of this, just to lay my bias on the table. I couldn't agree with those points more if I tried. That's an excellent vision statement, and expression of that. For 20 years in LA, I worked on this exact issue, combining healthcare with housing.
Yeah.
We started a new unit at the county there where I worked called Housing for Health. This is exactly what we did. I can't tell you enough how I think this is generally on the right track, and you're stating the right barriers and observations. I'm sure there's a million more that could be added to that. One of the things that I've noticed in being up here now is the lack of county hospitals as this hub idea. We were able to house, at this point, I went back for the 10-year anniversary of our project. We housed 21,000 chronically homeless people out of the hospitals in that period, doing exactly what this blueprint shows. But you don't have county hospitals in that way here. And so I'm curious how you countenance being able to harness all that, because the ED was our bread and butter. That's where we found our clients. That's where we found our participants, and we just loved them as much as we could into housing, no matter how many times they fell out. I'm just curious about that flight path, because that's where our clients came from.
That's a great call out. I'm going to give Lori a chance to answer that too. But what I do want to say is thank you for just seeing the vision. And I just want to call out that the Joint Office of Homeless Services has been a really meaningful partner in helping to flesh this work out more. And that doesn't mean that we're close to getting what we need or where we need to go. But I just want to highlight that they're doing an amazing job being strategic and responsive to the needs of housing service providers and a lot of other stakeholders at the same time. I would say, I'll leave it to Lori to answer the county hospital question, but we have a really valuable partner with our health systems here in the metro. HealthShare is an amazing organization that brings under its umbrella 5 different delivery systems, which makes it possible in the metro for every single OHP eligible person to have, at least in theory, access to the same providers as anyone with commercial insurance. And there's a lot of power and beauty in that collaborative. So I'm hoping over time, we come to realize a more just familiar relationship, again, that cross-sector cultivation of those relationships. So we're more familiar with the orientation. I think that part of it is we don't understand the orientation in which someone comes into a housing services organization, and housing services organizations don't understand the pressures that confront and exist in a health system setting. They're just different. And that's why that relationship building, I think, is paramount to addressing this from the get-go. You go ahead.
I think that's, yeah, absolutely. I think the way you call that is actually a critical issue often in some of the coordination that we do here, though. So I often joke that Portland and Oregon in general is a area that loves to innovate and they love to collaborate, but they don't necessarily love to coordinate. And it's kind of a hard thing to move through when you're trying to create systems. So here you have multiple hospital systems that sort of manage the ED in the Multnomah County area. It's likely to be Legacy and OHSU that really need to be in the conversation. So forming who needs to be in the room to do case conferencing is actually part of the obstacle to get over. We have a group that's actually coming in that's done this in other cities that's going to be doing our county level case coordinating. And one of the first things that we're going to be, they're called IHI, or the Institute for Health Innovation, and they're going to be working with us to really map out not just where do we need to go, but who currently does the work and where our coordination epicenters already happening, and how do we bring them together rather than rebuilding every single time. But then also, how do we use HealthShare? How do we use Care Oregon to really identify where these sort of hubs of transitions are and ensure that these are groups that are working with us rather than accidentally finding out in an afterthought that this conversation needs to happen. So I think you kind of hit upon why sometimes this work takes a little more time, right? Because it's not just the counties in the room, it's 3 different systems talking to each other and figuring out how do you use current systems like MyChart everywhere to get information to other groups that are also multiple housing systems.
Yeah, thank you for your thoughtful presentation. I share your frustration and also encouraged by the work. A lot of conversation in your slides about just the folks with disability and folks who are aging. Are you connected with Aging, Disability, and Veterans Services?
Yes, we are. I don't do direct service work myself, but I know that Northwest Pilot Project is very connected to the Aging and Disability program.
Because of course they provide the Medicaid piece and medical, so could find out very quickly who the CCO is. Also lots of opportunity. We also are coordinated access case conferencing. The county, Lori sits on this with the service alignment group with Joe Carr. I think that would be a really important place to connect because I think there's lots of places that are already making connections, and having the right folks from Northwest Pilot Project could be valuable for you and for us.
Awesome. That's great.
Funny you mentioned it. Joe is one of our group that's going to meet to try to figure out how this is going to work. Yeah. Oh, did you have a minute? Yeah.
Hi, so I'm from OHSU and I work in the transitional care program and for New Directions. And this is something that we've been struggling with too, is trying to just get into the housing part. And so we just got access to HMIS, but we're on the opposite end doing exactly what you're thinking and what you're trying to do on your end. So I get it.
I would love to get your contact information and talk more about that.
I would also like to just make a point about HMIS, which is it's not, as mentioned in the opening thing, a state-of-the-art system. We're We're working on fixing that over the next 2 to 3 years, and it's going to take a little time because we'll probably have to go to a new system. But one thing we are studying simultaneously as we move towards this new system is making sure we ask the right questions so we can design a system where we have something like they have in Contra Costa County, where you can get 2 or 3 flags in each system. So like the HMIS system will have some information you need to get to the healthcare system and vice versa. And that access is a little bit more intuitive and streamlined. And so I think it's something that is the elephant in the room always. It's not great. And it's one of the reasons we don't give access because it's so complicated, but we're working towards it.
Thanks so much. I agree, that the presentation was really rich and very, exciting for the future, and appreciate all the thought and partnership that has gone into it. And I just want to unshockingly sort of echo what, Jody said in terms of bringing, ADVSD, Aging, Disability, and Veteran Services is 5 different sectors. There's public guardian, adult protective services, long-term services and supports, which is the Medicaid arm. And then there's Older Americans Act programs as well. And then there's administration, that's the other one. And so I think that one of the really key pieces that are one of the key fissures that happens is that our community partners, the community partners for, I just left ADVSD and now I'm somewhere else. So I'm just going to still be 1 foot in there for 1 second, is that people either connect through the Older Americans Act programs, or they connect, and they rarely connect through the long-term services and supports or Medicaid portion of it. And so I think that becomes one of the key pieces, is asking where that long-term services and supports, who is there with that chair. And I'm going to throw one more piece down on this, is that just like in every other social service sector, there's a crisis in workforce. Yeah. And these types of organizations are really just focused on keeping the trains running, and don't have the capacity to be bringing these. I mean, the mobile homeless response team is one of the most innovative things that we've done in recent times in aging. And so I just think that, again, for folks in this room, is to really just be calling out, like, where is LTSS case management? Where is this Medicaid? Where are they at the table? And really echoing for the leadership of those systems to be finding the capacity to partner with you in these pieces.
It's funny you mentioned this. So, we've been simultaneously trying to figure out how to create a waiver hub. And it's in Multnomah County, it will be a collaboration between Department of County of Human Services and Joint Office. We already decided that's going to be the case. But as we brought that in, we realized the number of people who don't know anything about each other's programs, right, or how to navigate that. And simultaneously, in speaking with the consultants who are helping us in our case conferencing, when we decided on a population together, and this was a collaborative thing, they were like, well, do you want to bring TCHS now, or do you want to just wait? And I was like, why would we wait? It's so odd that, like, you just said 6 different acts and acronyms that I bet half the people in this room don't even know about. And it's critically important when you're serving someone to know everything at their disposal, not just one thing, and understand how they work. And so I think often, like, I often joke that housing is left out of the picture at the last moment. I think, like, Department of Human Services programs are also left, like, everybody's left out, right? It's this hilarious thing. You get 2 people in a room, not funny at all. And then a whole other group of people actually need to be there as well. And so I think this is exactly the mapping of what already exists before we start these conversations, and really having people in the room who can understand what's available to people before we start designing, not after the fact. So I just thank you for highlighting that, because I think it's something that, like, I will admit to knowing very little about, and I'm very happy to have partners in the room who can bring that knowledge base.
I would just add, I know there's a question out there, we'll get to you real quick. I would just add that, you make a really good point about the workforce and the crisis in capacity. And what I would say is, what I'm trying to cultivate here is, we need to put the right groups together that allow us to work smarter, not harder. Honestly, like, the basic issue that gives us the most trouble at Pilot Project, again, 55 and over, a lot of Medicare, Medicaid duals, which have competing benefits, sometimes with different plans. And again, we're just trying to get them into the doctor's office because their head's falling off, right? But what our biggest barrier is, where is the care actually happening? Where is the care coordination? What is the health plan? And if we could develop just a simple answer to that question of, here's the client's health plan, this is where you go to access the entirety of the OHP benefit, that would open up a lot of doors for us. Yep.
Oh, yeah.
Yep.
I think I saw a question. Yes. It's been a big part of the conversation. And initially we had heard Unitas and another platform and another one on top of that. So we were kind of getting into we'd really love to have a situation in which housing providers are not now bringing in 6 platforms simultaneously to get somebody to a rent check. It seems, so I think they are beginning to at least reduce down to at least just one, which probably will be Unitas for some of it. I think in many cases, the screening, partner that you saw there is going to do most of the interaction with Unitas, which will help a little bit, but we are definitely trying to figure out how it can speak to other systems a little bit more fluently, so people are not consistently doing double data entry or trying to figure out how to navigate a new system. We're also a little concerned understanding that many groups will be doing technical assistance and support for these systems, like figuring out who's going to be on the hook for really making sure that providers understand how to use the system. So we hear you. We're very concerned about it. I mean, I also, just as somebody who administers HMIS in our office, worry about where there are compliance issues with HUD around what we're supposed to be tracking when we start to move into homeless populations that are being housed, and trying to figure out how to track. So I'm just going to say I don't have a good answer. I have all of the concern amplified that we are bringing to the table. The platform that we will be investing in, you're asking, or I'm sorry. Oh, yes. Okay, sorry. Sorry, I missed that. The short answer is I don't know right now. And that's another thing we're trying to look at, which is how many navigation systems can we have in play before it gets even more confusing than not having any navigation system at all. Yeah, so I don't know, I guess, is the answer right now, and it's something we've brought up.
I would add about Unitas, they've been also a very good partner and are talking through a lot of these pieces with us along with HealthShare. I think right now, from a housing services perspective, one of the challenges that stands out is, again, it gets back to this bilateral referral. Happy to accept an HRSN referral in order to house someone who's in need. That's the work we do. That's the work that gives us a lot of, a rewarding feeling. At the same time, the person, when we accept that referral, what if we check in on them and there's a gash on their head, or their arm's numb, or they can't open their eye one day, right? We also need a clear pathway to send back the concerns about the person we accepted a referral from. And I think that hits into all of the workforce capacity stuff in the healthcare system. We just generally have a segmented healthcare system that, even if you're at a primary care doc, doesn't always have an easy pathway to get a referral to a specialist, right? Now we're talking about folks who have had challenges their whole lives engaging with the health system, trying to get a pathway in. And again, I don't view this as immediate work. I view this as iterative and kind of the direction we need to be moving in, and be conscious of the direction we're moving in with a goal, which is closing the gaps between silos so people don't suffer needlessly.
Yeah, I will mention too that we have, in the county, we have the Department of County Assets, which administers all of our various programs. And so we have somebody who's working with all the different programs, looking at this work to try to figure out, is there a streamlined way to make this, if not immediately, in the near future, a little less opaque and a little less confusing. Finally, there are some systems in Lane County, they are using a combination of Unitas and 211 to get people into the housing system and healthcare simultaneously. So we're trying to learn a little bit from what they've already done. So if there's something that exists that's at least a little bit intuitive, we can lean into that at the beginning and then sort of shoot for something that's a lot more cohesive and then also holistic in the near future.
Hi, I'm Stephanie with Do Good Multnomah, so service provider on the ground. And I had two questions, hopefully kind of quick. But the first one is everybody that we work with, unless they're in PSH and are typically veterans with their own healthcare, are chronically homeless or experiencing homelessness. So kind of that rollout and timeline, do you have any indication when sort of that next wave or layer to this would open up? Like, is this a
We do
2-year
not.
thing, a 10-year thing? Like, is it?
Well, it can't be a 10-year thing because it's a 5-year
That's
waiver,
right.
but
Is it gonna happen in 5 years?
which
Yeah.
actually creates its own anxiety because it's going
Yeah.
to have to roll out in waves. And part of this issue has been our system for prevention looks different than our system for housing people. So try to tie those two together is an internal process. And so we do not have a timeline for the next population. We are trying to create something that anticipates the next population while we're creating the first one. I wish we had an exact timeline on that. And I think my only other thought is that when you put together, I'm just gonna, as a thought process, somebody who needs rent assistance and has a chronic behavioral health issue and needs long-term services and supports, what I hear in the back of my head is this person is chronically homeless, not yet, or possibly has been in the last year. So there's a bunch of other questions we have right off the bat. So I think the upside of this kind of complicated algorithm that they're presenting for us is that we almost have to create something for somebody who is just a step away from being chronically homeless and then think about what it's going to look like. But I wish I had a timeline for you. I just know that we're kind of thinking about that in the forethought.
Second question, super quick. Came into this room pretty much not knowing just the briefest overview of Medicaid, OHP, that sort of understanding. Where should I go to learn more? Where can our team go to kind of dive into this? Like, I've heard a handful of resources, but if we just had to do a deep dive primer on all of these things.
That's a great question. I don't have the website addresses in my head, but what I can do as a follow-up is, or what we'll do is we'll send out like a write-up of what we heard here today with more information. And at the top, we can really include a bunch of really useful resources so you can do your own research.
Thanks. Scott, again, from the city, this will be the last thing I say. I promise this will be the last time I talk. I just want to encourage you because what in my past life, our experience was exactly this scenario. And then it's like, it feels like nothing, and then explosion. And that can absolutely happen. And it absolutely does. And it will. One of the things that I discovered was nothing. And then you blow everything up. Like all of a sudden you have 400 referrals in 1 month. And you know what I mean? And so like when it's good that we're getting to this plan, right? Or these ideas, but then what happens is you discover that those places where you think you're going to land don't have the capacity to handle the need. And so that sort of second chapter is, do we have specified dollars, staff, whatever, for our population specifically? Because if we don't, then what's going to happen is they're going to be channeled into a system that's already overwhelmed and doesn't have the added capacity. And if we're lucky, we'll get cuts in line. You know what I mean? Like they'll break off some space so we have it for our folks. But I'm just putting that out there that you might end up with too much of a good thing. And so the back end kind of has to expand. And we did not do that very effectively. And then we did. But again, just wanted to encourage that this can take place faster than you think. And then once it does, it almost is like you're too much of a big hit.
I wanted to speak to that a little bit with both the question we just got, which is when's the next population, which I think part of it is not knowing the size of the bite we're about to take. So not knowing the next step, but also one of the reasons we talked about focusing in on this really discrete population was because we have enough data to kind of guess how many people will serve at first. And we're not just wading into a really deep, like basically pool and trying to figure out how to come up for air. So I think often some really amazing policy comes out of these little incremental bites to try to figure out how to do it right before you jump into everybody else, and especially in a city with so many people who have critical need.
I would just add too that, like, you know, I started the presentation kind of drawing a dichotomy between the need for crisis response as well as upstream housing retention services. And I think, number one, it's pulling the right groups of people together to have cross-sector responsible dialogue that does not involve blaming or shaming, because nobody got us into this boat on their own. This is a collective collapse. And we have some really good leadership now to work with to reframe things. And then the next piece is, what is the most responsible step to take, not now, but for like the next iterative state, right? And what I'm arguing for is broader connectivity with the health system is actually like an underlying piece here. It's not looking for immediate access, but if housing service providers are able to identify the CCO, that opens up a relationship, that opens up the ability to communicate and co-manage. And I just want to highlight again that the Joint Office has stood up in this space as real leaders, promoting this work, promoting cross-sector collaboration. And I think they see the big picture on it. So I'm very proud of that.
I wanted to piggyback on the comment about capacity. First of all, I'm Julie Ibrahim, CEO for New Narrative. As a nonprofit provider, I think it's really important, if the counties are going to be hubs, that they have the capacity to do the administrative part, the billing and the payment. Because we as the providers, we confront these services for a couple of weeks, maybe 30 days, but 60, 90 days and more, that's going to be a no-go. Because I can imagine we're going to be using these services quite a bit with our population. So hopefully the counties are getting some of the capacity money to build their administrative staff for this.
The application for the CCBF funds included basically a lane for hubs. And so each county is actually applying for that work. And then we're also actively working with HealthShare to really define what kind of capacity we should be getting, to understand what we're going to need to do, and to talk a little bit about what other administrative functions need to be in place to ensure that we're considering the syncopation of the benefits, and then also how we're going to ensure that the providers who are choosing to participate in this really have enough TA and support to really move forward. So it's a collaborative effort to really shore that up.
I would say a lot of it too goes to your question of, we need to elevate the level of dialogue around OHP in the housing services world, because Medicaid is not something to be afraid of. Medicaid is actually, it was passed by Lyndon B. Johnson as part of the war on poverty to give a social safety net to the very communities that we serve. That is its legislative intent. And so we need to warm up to the idea of collaboration with, and I New Narrative does amazing work actually in this space. You kind of straddle, you straddle all the sectors and you do great. Pilot Project doesn't really have its foot in healthcare. That's where we're trying to get to better understand it, to become more sophisticated, to navigate folks to the right resources.
That's funny. I actually I bank with United. So I have that. I don't know if I'm supposed to say that plug, but Unitas is a technological application platform that is basically a warm handoff platform. So effectively, you can use it to find a provider. It's the equivalent of an internet call and response kind of program. So you would be able to find a provider, make an appointment with a provider, and then get feedback that they've accepted the referral. The same idea would be happening in that system. So it's just, it's basically an app. Yeah. I love that. I also will mention we're going to be having quarterly provider conferences of some sort from here on out with the joint up. So I think, and we've talked about having some virtual sessions as well. So perhaps what we're hearing is it would be good to have one when this is more solidified around that. Yeah, okay. Yeah.
Did we wear you out? Did we wear you out? Yeah.
Maybe this question's already been asked or answered at the beginning, but how many times can this service be accessed by an individual? Is it based on their health need? Like if someone had 5 different health occurrences, would they qualify 5 different times? Or is it based on the individual, like one and done?
That is a good question. As I understand it, it's only one time per individual, which is why the 6 months has given us a lot of, well, nerves in trying to figure out how to get people to other needs afterwards. The other thing we did clarify is it's one time per person per household. So technically, if you had a household with 3 qualifying individuals, you could sort of braid those 6 months together or use them episodically. But as I understand it, it's one time per person.
I got a follow-up.
Oh, yes, go ahead.
Yeah, so my follow-up is, so if someone's accessing this service based off their medical need, but this medical need makes them, they're still able-bodied, and while they're in housing, they incur another a traumatic event that now makes them non-able-bodied. What does that look like, to like access the service? Because, 6 months is too long, 24 months is too long. Maybe, consider permanent support housing. Exactly. I was just kind of curious, folks that work with the vulnerable population, what does that look like on that second?
So I would split a couple things. I would say that the waiver benefit, the HRSN benefit kind of stands alone as a package that you need to qualify for and be deemed eligible for, and then go through a process to receive all of those services. I think my portion of what I was talking about around access to care hits on exactly what you're talking about. We are constantly working with high need individuals who, again, like you said, you might pass them on the street and not know that they're disabled. They might not have a noticeable disability, but they come in with acuity and trauma of the likes that we haven't seen before in our agency. And so from our perspective, what's really important is not letting this tool, this innovative tool that's getting national recognition in the waiver, kind of just sit out there as a standalone tool without a broader vision to connect it to people who are consistently encountering setbacks or trauma in a housing related setting that requires joint accountability with health systems to kind of address the whole person's needs. That's how I view this working.
Exactly. This was exactly why we sort of urged for some sort of hub as well, is the notion that this cannot stand alone for certain populations. Really, a lot more is going to be needed. And with other resources in the mix, there's potential to think about what other places can people be connected to so they have longevity of services that meet their need. They're not just, as we said, kicking the can down the road 6 months and experiencing homelessness at that moment instead.
Okay, just so one and done forever, for a year, for the 5 years?
I don't know that I have an answer to that, but I will get one.